Good afternoon. Good afternoon, everybody. Good afternoon, members in the front row. We are beginning our hearing today. Thank you so much. Welcome to the Health and Social Services Subcommittee on Appropriations. I'm Delegate Emily Shetty, Chair, joined by my wonderful Vice Chair, Dana Jones, and our amazing members and our counsel, Joe Gutt-Burlett. Thank you, DLS analysts, for your thorough analysis. Today we are going to be covering the MDH, Maryland Department of Health Overview Budget. And it is such a beautiful, giant budget that we have three amazing analysts assigned to us today to present their thoughts. So we will begin, as always, with the three of you. You may introduce yourselves as you go along, and we look forward to your thoughtful presentation. Thank you.
Thank you, Chairwoman. My name is Naomi Camaro. I'm the budget analyst with DLS. I'll let Ann and Victoria introduce themselves before we start.
Hi, Ann Braun, Deputy Operating Budget Manager, and I cover Medicaid and the Health Regulatory Commissions.
Hi, I'm Victoria Martinez, also a budget analyst, and I cover the Office of Healthcare Quality, Health Professional Boards, and DDA.
So the entire Department of Health budget in fiscal 27 is $23.2 billion, which is a 4% decrease from fiscal 26. That is accounting for planned reversions and fiscal 26 deficiencies, as well as some general fund and special fund reductions and appropriations contingent on the BRFA, which we'll talk about in a bit. On pages 5 and 6, we've summarized some of the federal grants that were thought to be at risk with the rescissions and cancellations by the federal government, announced by the federal government this summer. MDH to date has not lost any funding, but we have listed out those grants and the amounts that MDH received in fiscal 26. All of them have continued due to resolved or ongoing litigation. On pages 7 and 8, we point out some of the major proposed deficiencies that are included in the fiscal 27 budget plan. The full list is in one of the appendices, but I'll just point out that these proposed deficiencies total a net increase of $2.5 billion to the fiscal 26 appropriation and include about $718 million to cover fiscal 25 shortfalls in provider reimbursement programs in BHA, DDA, and Medicaid. On page 8, we've summarized the one planned reversion in the department is for $16.7 million in BHA. This is due to unspent grant funding by local behavioral health authorities and core service agencies that deliver behavioral health services locally. There was a provision in the BRFA last year that authorized rather than required unspent grant funding to remain with the LBHAs and CSAs at the end of the year. Because of that provision passed, that unspent funding can now be transferred back to the Behavioral Health Administration. So that's what that represents. The pie chart lower down on that page shows the breakout of the fiscal 27 budget by purpose. And as you can see, a majority of the budget is dedicated to provider reimbursement payments for healthcare services across the state. About 60% of the total budget is for Medicaid, and then there's slightly smaller portions for BHA and DDA provider reimbursements. On pages 9 and 10, we've summarized the major changes to the budget between fiscal 26 and fiscal 27. So again, the total budget is decreasing by $972.8 million. And that decrease is driven mainly by that $718 million that I pointed out earlier to cover fiscal 25 shortfalls. I also want to point out in that same section on the page, $49.3 million in funding that was not eligible for FEMA reimbursement to cover COVID-19 related expenses in prior years. This appeared as an increase last year, so just want to point out that this has been in the budget before. And then above that, there's also a one-time payment in fiscal 26 for non-Medicaid eligible expenses in DDA, which results in a $39.3 million decrease to the budget. In the provider reimbursement section, we've summarized some of the changes. So not accounting for that fiscal 25 service-related deficiency, this would be the change between the fiscal 26 budget and the fiscal 27 budget as introduced. So there's a decrease in behavioral health provider payments, decrease in the DDA provider payments, and increase in Medicaid payments. And these totals do not include any provider rate increases for behavioral health, DDA, or the Medicaid LTSS provider payment, for providers, excuse me. On the next page, just briefly, I also wanted to mention that there's an $80.6 million decrease in the budget due to delayed major IT development projects that the department has put on hold in fiscal '27. On pages 10 and 11, we've summarized some budget actions that are related to provisions in the BRFA. So most of these will be discussed later in the individual analyses. But I did want to point out the $20 million in special fund decrease, which is contingent on a provision reducing the mandate for the Consortium on Coordinated Community Supports. Pages 12 and 13 cover our personnel discussion. The exhibit on page 12 shows the number of filled and the number of vacant positions, as well as the percentage of filled positions across the entire department in each year between 2022 and 2026. You can find a full list of authorized positions from fiscal 25 to fiscal 26 in the appendices. The next page describes the voluntary separation program, which the governor introduced last year. MDH abolished 47 positions under this program in fiscal 26. 24.3 of those were vacant, and then this chart just shows those positions by office or agency. So you can see the majority of those abolished were in the Public Health Administration, and more than half of those were vacant positions. Page 14 begins the discussion of the issues that we've raised in the analysis. So the first one has to do with concerns about the fiscal 25 closeout. In the fall, the Department of Health reported $411 million in DDA, in shortfall in DDA and Medicaid, which are included in the fiscal 26 deficiency that I mentioned earlier of $718 million. The difference between those two numbers include insufficient accrual, so under budgeting essentially for fiscal 25 services that had claims in fiscal 26 in BHA and Medicaid. Within some limitations, MDH is able to transfer funding between certain provider reimbursement programs that may have surpluses to cover shortfalls in other areas. And so this page summarizes some of the actions that MDH has taken, including realigning $139 million from non-Medicaid behavioral health programs to behavioral health Medicaid programs and traditional Medicaid. And so we've pointed out that the behavioral health Medicaid program was still short in fiscal 26, and so we have asked MDH to comment on why it transferred funding out of BHA that could have been used to cover other shortfalls in the behavioral health Medicaid program. And we've also asked them to indicate when budget amendments will be submitted reflecting those realignments. The last portion of this page, we just note that the importance of monitoring the budget throughout the year because there can be unexpected changes in utilization and spending. And so DLS has asked MDH to comment on its process for monitoring utilization and spending throughout the year to identify potential shortfalls. The last portion of this section describes some of the findings of a fiscal 2025 closeout audit by the Office of Legislative Audits. So OLA conducts annual closeout audits across the state. And for fiscal 25, they found that MDH lacked documentation demonstrating that it had requested and recovered eligible federal funding. And so we have asked MDH to comment on the dollar value of the accrued revenues reported in the audit that it's received to date and the timeline for recuperating any remaining funding. This mirrors similar findings in prior OLA audits. And so to rectify that, MDH has hired an accounting firm that it's working with to improve its processes and recover any remaining federal funds. We've asked MDH to comment on the status, length, and total cost of the contract, including the amount included in the fiscal 27 proposed budget, as well as discussing planned and implemented improvements to its accounting procedures, particularly related to fiscal year-end closing.
Great, so I'll be covering the second issue that has to do with the Rural Health Transformation Program. This was established in the One Big Beautiful Bill, or OBA. It's a CMS program that will distribute $50 billion to states through 5-year grants. Half of that funding was allocated equally across states with approved applications, and the other half is up to CMS's discretion. On December 29th, CMS announced that Maryland's award for the first year would be $168 million. In terms, and then looking at page 17, in terms of the geographic regions that would be considered rural under this program, MDH chose to use the definition in state law for its grant application, and so that includes the 18 labeled counties shown on the map on page 17. MDH's grant proposal described 2 overarching types of fund opportunities. The first is immediate impact funding for projects that are shovel-ready and can be implemented quickly. The second is transformation funding for projects that require more planning or more lead time. The top of page 18 shows MDH's planned initiatives, and so I'll highlight just a few items. The first is that MDH would put $26 million to strengthen the rural health workforce. This would include funding for apprenticeship and training programs and establishing a new area health education center in Southern Maryland. The second and largest initiative is $126 million for access and innovative care, which includes primary care activities that are managed by HSCRC. It would also include improving billing practices in local health departments and supporting school-based health centers. The third initiative is $15 million for nutrition improvement programs or efforts, such as providing cold storage or refrigerators for healthy food and produce. And so this is just a sampling of the projects that were mentioned in the grant application, and there were many other projects mentioned. So we've asked MDH to discuss its spending plan for the components within the main initiatives and to provide the timing for the development of competitive grant programs that would use to distribute these funds. The budget as introduced doesn't include federal funds from this program, mostly due to timing of when the funding was announced. And so MDH is also asked to discuss the timing and methods for bringing the funds into the budget. So then moving on to the third issue that begins on the bottom of page 18. This relates to the Cigarette Restitution Fund. That's the fund that holds annual payments the state receives from tobacco manufacturers under the Master Settlement Agreement. Pages 19 and 20 discuss ongoing litigation with tobacco manufacturers regarding Maryland's enforcement of the settlement statute. When Maryland is found to have diligently enforced the qualifying statute, the state can receive additional CRF payments that are currently held in a disputed payments account. For sales year 2005 through 2007, an arbitration panel decided in Maryland's favor, and so the expected payment from that decision was at least $25 million. More recently, in September 2025, however, Maryland settled with a subset of tobacco manufacturers for sales years 2005 to 2025. This is expected to result in a one-time payment of $37 million, and that is expected to be paid in April 2026. And so combined, those two payments could be $60 to $67 million total, but the timing and amount of that full payment is not finalized. And so all payments from the litigation are received in a separate account within the CRF, and that is required to supplant general funds for the HBCU settlement payment. If you turn to the exhibit on page 21, this shows CRF revenue and spending in the budget. And I'll highlight that the fiscal 27 allowance assumes that Maryland will receive $70 million in revenue to the separate account. This year's BRFA includes a provision that expands the use of funding in that separate account above the first $35 million to support uses other than the HBCU settlement. For fiscal 27, you'll see the first $35 million from the separate account is budgeted for the HBCU settlement. The total $61 million settlement is fully supported in the fiscal 27 allowance, with the remainder being paid with general funds. As I mentioned earlier, the timing and the final amount of the combined payments from litigation are still uncertain. And so what the BRFA provision does is allows revenue from the separate account that is more uncertain or may not materialize to be budgeted for other uses. And the budget fully funds the HBCU settlement with a combination of CRF and general funds, as I said. And so then turning to the remaining $35 million in estimated revenue from the separate account that's budgeted in fiscal '27. Notably, most of the revenue is not distinguished from the other CRF revenue, with exception to $8.4 million in Medicaid expenses. The budget includes $8.4 million in general funds for Medicaid that would be reduced contingent on the enactment of the BRFA provision. And then there are equivalent special funds budgeted, but they do not have language that makes the special funds contingent on enactment of the BRFA provision. And so DLS recommends adding language to make the $8 million in special funds also contingent on the BRFA provision, so that if the BRFA provision didn't pass, you aren't double budgeting, so that you wouldn't have the special funds if the BRFA provision didn't pass. That recommendation will appear in the Medicaid analysis. And so that accounts for $8 million of the additional revenues to the separate account, but there are no contingent general fund reductions for the remaining $27 million. And so that means that if the BRFA provision didn't pass, then CRF-supported programs would be underfunded by that $27 million. Again, as I described, the timing and amount of the revenue to the separate account isn't final, and the most recent estimate was $60 to $67 million, while the budget assumes $70 million will be received. And so considering the $35 million in revenue to the separate account might not be realized for those other CRF uses, MDH is asked to clarify how any reduction in CRF spending would be applied across those other programs and how the CRF-supported programs would be impacted. On page 23, the first two items describe other BRFA provisions that affect cigarette restitution fund spending. The first relates to a mandate for $8 million in CRF each year through fiscal 2029 to support the Community Health Resources Commission Fund. That fund is used for operating grants and operations of MCHRC. The BRFA would waive this mandate in fiscal 27 only, and so the budget as introduced reduces $1 million in CRF from MCHRC. That funding will instead be supported with MCHRC's fund balance. And then the $1 million in CRF is reallocated to Medicaid to provide $1 million in general fund savings. The second BRFA provision reduces the CRF mandate for the Tri-County Council for Southern Maryland to $700,000 each year beginning in fiscal 27. And so this results in $300,000 in CRF savings each year. The last note in this issue is that statute requires 50% of CRF expenditures to support the programs listed on page 23. We would typically exclude revenues from the separate account when determining whether this requirement is met, but because $27 million from the separate account isn't delineated in the CRF uses, we can't confirm that the budget meets this requirement. And so MDH and DBM are asked to propose a BRFA amendment to waive this requirement in fiscal 27 only to align with the budget. And so that concludes that issue. I'll pass it to Victoria for the final issue.
So the last issue that we discuss is on efforts to reduce the registries for the home and community-based services programs that are administered by MDH. MDH maintains registries for the waiver programs for individuals who have requested services but have not completed the eligibility determination or application process. In efforts to reduce the registries, the End the Wait Act of 2022 required MDH to develop plans to reduce the wait list for Medicaid waiver programs by 50% by fiscal 2028, beginning in fiscal 2024. Exhibit 6 on page 25 shows the current status of the MDH-administered waiver program registries. In fiscal 2025, the Community Options Waiver Registry increased by 5%, while the DDA Community Services waitlist decreased by 13%. Reducing the registry involves both increasing the number of authorized and funded slots, as well as fully utilizing already available slots. Exhibit 7 on page 27 shows the utilization of available slots in fiscal 2025. Available slots remained underutilized in the Community Options Waiver, where 33% of available slots were unfilled. DDA's Community Pathways Waiver Program, however, utilizes most available slots with only 3% of slots unfilled. Since the Community Options Waiver had the largest registry, Exhibit 8 on page 28 shows the results of additional outreach efforts for that waiver program. Although outreach has increased in fiscal 2025 and even surpassed some of their outreach efforts for that waiver program, the registry remains high due to a low response rate to invitations, high rate of ineligible applicants, and steady influx of new registrants being added to the registry. Some additional updates on End the Wait activities provided by MDH include efforts to improve provider capacity and staff capacity across waiver programs. Exhibit 9 on page 30 shows the additional staff needed to implement the waitlist reduction plan, with a total of 73 positions needed across waiver programs, especially within the eligibility determination division. DDA had the highest need with a total additional need of 31.5 positions. However, DDA currently has 30 vacant positions, so staffing efforts should first focus on filling already available vacant positions. And that concludes the discussion of this issue.
That concludes our presentation, but we'd be happy to take any questions.
Thank you so much for the thorough presentation and discussion. Do any colleagues on the committee have any questions for our analysts? Okay, seeing none, thank you. As our friends from MDH make their way down, I just want to take a moment to introduce some friends in the audience. So we have some students who are shadowing some members today. So I know I have a shadow. Do you want to raise your hand? There she is, Ami Patel. She is at St. Mary's, a junior, majoring in computer science and minoring in political science, right? Public policy, political science, yeah. And then I believe there is another delegate with a shadow, if you'd like to introduce them.
Oh, perfect. Thank you. Thank you, Mr. Mike Mann, for the day. We appreciate you. I, too, have a shadow from Johns Hopkins University studying public policy. She is here with us for today. And I know I'm going to say your name. Just say it out loud. Anaga. I keep seeing it on the paper, and I don't want to pronounce it like that. I'm giving you my own name. But thank you for being here, okay? All right.
Madam Vice Chair.
Thank you so much, Madam Chair. We have the newest member of my team here, Megan Studley. There she is. She's not a shadow, she is a terp, and we are so happy to have her in the office. Thank you.
Megan is one of my former students. I see a couple others in the audience too. Makes me so happy. Okay, thank you so much. Welcome, Madam Secretary. Is this your first budget hearing in the General Assembly or just in the House?
First in the General Assembly.
Wow, we are very privileged to welcome you here today. Thank you so much for joining us, and thank you for the good work that you and your team have done over the last since the session. I know you came in right after session and really hit the ground running, and it's been a pleasure getting to know you and your teammates that you've brought in. So we'll just turn it right over to you for your presentation, and then we'll do questions from the members.
Great.
Thank you.
Well, thank you. Thank you, Chair Shetty, and thank you, committee members. For the record, I'm Dr. Mina Seshmani. I'm the Secretary of the Maryland Department of Health. And the department thanks the governor, the Department of Budget and Management, and the budget committees for their support. We thank the Department of Legislative Services for its insightful budget analysis. It's really my honor to have the opportunity to appear here before you to discuss the Maryland Department of Health's priorities and how the Moore-Miller administration's fiscal year 2027 budget proposal will help us to protect and advance the health and well-being of all Marylanders. I'm pleased to be joined here today with members of my leadership team back here, all of whom really embody the heart and the mission of the MDH workforce, putting Marylanders first. We stand ready to answer your questions and engage on public health matters today, as well as in future MDH budget hearings in the coming weeks. Now, a core tenet of the governor's budget and the MDH mission is protecting our people. What we do and why we do it centers around Marylanders. We want Marylanders to know that we have their back, now more than ever. And I'd like to take this time to highlight how the governor's budget will help us to deliver on our priorities and commitments in some key areas. First, vaccines. Vaccines remain one of the most powerful public health tools that we have to keep ourselves, our families, and our communities healthy and safe from disease. As federal government uncertainty around vaccine policy has raised questions for many, Maryland has taken important steps to ensure broad vaccine access for its people. Last fall, we launched a first-of-its-kind effort, the Maryland Vaccine Program, or MVP. Under this program, local health departments are providing thousands of life-saving immunizations, such as influenza, RSV, COVID-19, hepatitis A and B, and shingles, free of charge for uninsured and underinsured adults throughout Maryland. The proposed budget continues that investment with $2.9 million in state funding. And though not part of the budget discussion today, we are also very excited about the governor's VAX Act, SB 385, for safeguarding access to immunizations, screenings, and preventive services for Marylanders based on science and clinical guidance. Next, I'll turn to Medicaid. For Maryland Medicaid, the proposed budget provides significant investments, with $13.8 billion in total funding for delivering health care to more than 1.4 million Marylanders, including 197,000 children through the Maryland Children's Health Program. The budget includes no provider rate cuts or benefit cuts. It also supports implementation of the various requirements under H.R. 1 as we work to protect Marylanders from coverage loss and service disruption. These resources will be instrumental as we put the staff, systems, and processes in place to verify eligibility, process redeterminations, and ensure access to needed Medicaid services and benefits for current and future enrollees. Next, I'll turn to developmental disabilities. The governor's budget proposal is focused on protecting the long-term sustainability and future existence of the Developmental Disabilities Administration program so that it can continue to serve Marylanders with intellectual and developmental disabilities. The fiscal year 2027 budget includes $3.2 billion in total funds for DDA, including $1.7 billion of general fund support. This reflects an increase in state funding of more than $920 million, or 117%, during the Moore-Miller administration. Last year, DDA coordinated 88 training events, 41 work group meetings, and participated in more than 100 community engagement events to collect feedback about program sustainability. DDA has regularly met with representatives and participants from both the self-direction and community provider-managed delivery models. And DDA will continue to host hybrid and in-person meetings with community partners, both during and after this legislative session. And the reason we do this is because it is critical that we make the necessary adjustments to ensure that the DDA program continues to comply with the federal waiver requirements and to ensure its sustainability into the future so that it can continue to serve Marylanders. The Governor's Office and we at MDH are committed to continue working with you, the Maryland General Assembly, and with our community partners to come to the best possible outcome by the time the legislature passes the budget. I'll next turn to behavioral health. The governor's budget continues to make investments in Maryland's behavioral health services, with $3.9 billion total funds budgeted in fiscal year 2027 for the Behavioral Health Administration and Behavioral Health Medicaid. MDH's Behavioral Health Administration helps ensure more than 330,000 Marylanders receive mental health and substance use services annually. The governor's budget includes funding for adolescent inpatient substance use disorder services through partnerships with Brooklane and Mountain Manor Treatment Centers. It also provides funding to support bed registry and referral system care traffic control, advancing technology to support access to the behavioral health continuum of care. Turning next to our facilities, the department's healthcare system operates as an essential safety net for more than 1,800 of Maryland's most vulnerable residents across 11 specialized facilities. The budget includes continued resources to operate pediatric overstay units at the John L. Gildner Regional Institute for Children and Adolescents in Rockville, and to address ongoing renovation needs at Clifton T. Perkins Hospital, which would increase the department's ability to address the court-ordered wait list. And now, moving to the Rural Health Transformation Program. Though not part of the governor's allowance, late last year, Maryland received more than $168 million in federal funding for budget period 1 of 5 of the Rural Health Transformation Program. This is an incredible opportunity to transform our rural health workforce, to promote sustainable and innovative care for rural Marylanders, and empower rural Marylanders to eat for health. We will deliver dollars quickly and directly to rural communities and rural providers, with the majority of funds being distributed through competitive processes. So in closing, thank you for providing me an opportunity to highlight the governor's budget and how it will allow us at MDH to continue to protect Marylanders while building a state government that is more responsive, transparent, and focused on the people we serve. We look forward to working with you, the Maryland General Assembly, with advocates, and with the community as we pursue our collective vision of a high-quality healthcare system that produces the best possible health for Marylanders across their lifespan. Thank you.
Thank you, Madam Secretary. We really appreciate you being here and bringing your wonderful team. Thank you all. I know we have questions likely from my colleagues, so we'll start with friends in the front row. I see Delegate Stonko.
Thank you, Madam Chair. Thank you, Madam Secretary and team. I just wanted to start out with some questions around the deficiency appropriations from prior years. And then for our tech team, there's a couple of follow-up questions as a part of this as well. So the figure, the deficiency appropriation at $2.5 billion necessary to backfill FY25 and 26 budget shortfalls. This accounts for more than 10% of the FY27 budget. Recognizing there's challenges for future service needs, can you talk to us about the timely tracking of these service cost utilization, and most importantly, what actions you've taken and put in place that doesn't continue? I know it's been an ongoing issue.
I can start at a high level, and then, Nick, I'll turn it over to you. at a high level, we have been improving our forecasting tools. And I think specifically with the DDA, where with our new method of paying providers that enables us to have more predictability and data on an ongoing basis to have stronger projections in terms of utilization. That being said, as you mentioned, at the end of the day, these are forecasts, and some of with Medicaid and DDA, it's seeing what utilization ends up being. And so another area of focus for us is being able to have that ongoing monitoring as well of what the cost trends are looking like, what the utilization trends are looking like, so that we can, continue to adjust. And I'll turn to Nick for some more details.
Sure, I'll add some more detail, but I want to note as well, Secretary's remarks were opening remarks before we submit or present our testimony in response to the 3 items that our DLS colleagues put forward, and this is one of the items. So I'll speak to this issue, and then if it works for folks, we can get back into delivery of our testimony responding to the DLS analysis points. Okay. So, with respect to use of, monitoring utilization, incorporating data into our projections to identify potential shortfalls, just want to present our process. So we utilize a quarterly projection process that we undertake through a statewide process that DBM coordinates. This happens in the first, second, and third quarters. These are large endeavors for our department. It involves dozens of people across our 50 budget programs. Services budgeted within Medicaid, DDA, BHA, they involve more complicated projections that lend themselves to use of data, right? And so for Medicaid, utilization enrollment data is used to generate quarterly projections for entitlement programs, somatic services, behavioral health Medicaid, MCHIP, Medicaid Office of Finance, gathers monthly to share budget expenditure reports with their programs. Budget variances are flagged for monthly review for incorporation into the quarterly projection and also for consideration for top-level decision-making by leadership. DDA uses its utilization enrollment data to generate quarterly projections for its Medicaid waiver program, Community Pathways. Since all providers have transitioned into LTSS effective September 2024, DDA has been able to more accurately forecast expenditures of their current year services, and there's more to say there in a minute. So these processes accommodate data-informed decisions. And finally, want to speak to data in BHA. So there's some really rich data that the ASO gathers. The ASO transition from Optum to Carelon has kind of embargoed that data until the transition's complete, until the various interfaces happen, until we're able to kind of validate data and finish the data mapping, which is, it's been ongoing, and it's expected to conclude this month. Unlike the previous ASO transition, there'll be no data lost. This whole period where we've been in the transition awaiting data, we're going to have that data. So that's good news. And we believe that all the care and attention that's been, brought into this transition is going to lead to, more accurate billing system, cleaner billing system, and, data that lends itself, really well to projections. So we're looking forward to gathering and sharing that data very, very soon. With respect to the deficiencies this year, I think on a general fund basis, it was over $650 million, for our department this year, almost entirely within DDA, Medicaid, some in BHA, a little bit more elsewhere. DDA was the lion's share of that, right? Almost $400 million of general funds. So, part of this, I think, ties back to 2 items. So one is the services accrual for the current year services. It's, we haven't, last year hadn't had full year of experience kind of managing this accrual. It wasn't fully budgeted clearly at this point. We can see that. So I think we'll have a handle on that, and through the deficiency this year and through the FY27 budget, we believe the accruals accounted for. And so that's one item which was significant. The other item which was significant was reconciliation of the prospective payment system that stretches back many, many years. So just we closed out, reconciled the PCIS2 claims, the win-loss with the providers where we outlay funds in the beginning of the year, claw it back as we kind of get data about their expenses through the year. So there was a multi-year reconciliation effort that didn't conclude until after session, and that was also significant.
Sorry, Delegate, if I may, really quick. Did I hear you correctly that your panel had not completed your testimony? I apologize. We were so excited to ask you all questions that we just jumped right in.
Sure, yeah, we want to be able to respond to the specific points
My
raised by,
apologies, colleagues. I did not realize that. I should have spoken with you beforehand. But we just are so excited you're here.
We are equally excited.
Oh,
so
good.
It's good.
Okay, so we'll turn it back over to you all, and then we'll ask questions after you all are completely done. Thank you.
Sure, and we just want to start off by thanking everyone for their cooperation and support, and the Governor's Office, DBM, this committee. We also thank DLS, our colleagues, for their always insightful analyses. So we'll start off with the first question that was asked. It was about comment on why we realigned funding out of BHA in our FY25 closeout that could have been used to cover shortfalls in BHA Medicaid program. So our response is the current year deficiencies for FY26 reflect, projections for this year for FY26. In the case of BHA, the items that are the subject of the deficiency don't tie back to service year 25. They're not part of a carryover claim. Within BHA, it's tied to FY20 or service year 26 services. We could have, there's a lock on these budgets, we could have, not done the deficiencies, realigned at closeout or some other point because we have that ability through the budget language, per DBM practice. The budget bill reflects projections and makes deficiencies adjustments accordingly. And I apologize if there's more of that question we're missing. We're happy to talk it out some more. That's our understanding at this point. And so the next question was about the question about data and about the budgets for our largest, the services budgets, and how we project, and some of one behind the deficiencies, especially in DDA. So we've just discussed that. So next set of items were about closeout audit and our Schedule G, which is the matching of revenue and expenditures for federal funding, and it also about our contract with Deloitte. And so we're first asked to comment on the dollar value of the accrued revenue supporting in the audit that's received to date and the timeline for receipt of any remaining receipts. And so, as of January 21st, we've received $752.8 million of federal revenue tied to our closeout from FY25. So if we compare that to this final Schedule G we gave to our comptroller, General Accounting Division, at closeout, which was $758 million, that leaves about $6 million that we're following up with programs now just to confirm liquidation of expenditures, why that hasn't happened, any kind of tie up with revenue claiming so we can move that along. So we also want to just make a comment here. Part of what I think OLA was speaking to in their finding was timing of revenue receipt, within the first 2 months. So we want to talk about why that might not always happen. With regard to Medicaid, right, medical assistance and Medicaid DDA, also for behavioral health services, which is a really large part of our federal fund accrual. We have, providers have up to a year to submit claims to us. We have up to 2 years to claim revenue from the federal government. And so, while the majority of, or a large portion of accrued claims we receive revenue within the first 2 or 3 months of the fiscal year, we're going to be receiving revenue all year long because providers, will continue to submit claims for service year 25 through the end of this fiscal year. It happens. And so we want to note that. We also note that for our federal grants, our categorical grants, we have 90 days after the close of the grant to submit for reimbursement to the federal government. And so there's some cases where that might also explain a delay where there's an item where we're not claiming within the first 2 months. And so in terms of the next question, which is commenting on, and sorry, one more point I want to make before we go to the next question. This is all about revenue matching to associated expenditures. And we want to make the point of there was no, we don't believe any federal funding is at risk. We believe that there's not going to be a general fund ask, following this reconciliation, which has substantially happened. So I want to make that point in case there's any lingering concerns. So for next question, MDH should comment on the status, length, and total cost of this contract. That's the contract with Deloitte, our partner who's brought in to assist with our audit cleanup, including amounts included in the fiscal 27 proposed budget. We should also discuss planned and implemented improvement to our accounting procedures, particularly related to fiscal year closeout. So we have a task order with Deloitte through the statewide contract with MDOT, Department of Transportation. The task order began in August of 2023. It runs through May 2nd of this year. The task order total currently is $14,540,000. We note that we're currently working with MDOT to increase the task order by $112,000 to improve accounting and grant processes within the Office of Minority Health and Health Disparities. And then for the next question, I want to note the vast majority of our OLA closeout audit findings, flagging areas of concern, most notably matching revenue to associated expenditures, documented in our Schedule G, stem from records dating back to 2015 and the impact of the 2021 cyber attack. So we're not just managing today's books, we're also fixing a decade of accounting backlog. Since 2022, our forensic efforts, in partnership with Deloitte, have successfully identified and cleared more than $3.1 billion of the $3.5 billion legacy Schedule G balances. So it's been a long journey, and significant progress has been made in clearing the backlog of legacy transactions through reconciliation, while simultaneously strengthening financial management with controls through targeted process improvements and automated workbooks. So together, these changes increase transparency, repeatability, and accuracy in day-to-day operational execution and improve fiscal stewardship. We've included for the record in the written testimony a table that shows 14 of the 94 implemented resources developed by Deloitte in partnership with our programs to strengthen accounting and claiming processes that feed into our fiscal year closeout. So these processes that we've identified in the chart and the exhibit tie back specifically to Schedule G. For each of these resources listed here and part of the overall 94, there's been a related reconciliation effort that collectively has addressed over $6 billion of revenue allocation errors. So again, long journey, huge progress. The resources provide automation of certain technical processes involving payments to providers, federal revenue draw, financial reporting to Centers for Medicaid and Medicare, and reconciliation of the data interfaces between our claiming and financial systems. The resources reduce manual effort necessary and allow staff to work on higher value work, such as analysis and investigation. So we're in the process of scheduling a meeting with OLA to review the efforts that we have undertaken in partnership with Deloitte. We will use this meeting to discuss the level they would like to see with respect to Schedule G and matching revenue and expenditures, and whether our efforts match OLA's expectations heading into fiscal year closeout for FY 2026. Okay, we're also exploring the possibility of amending closeout processes to distinguish between short and long-term receivables to flag recoveries we expect will not be received within the first 2 months of the following fiscal year, such as the carryover claims we discussed in Medicaid, DD, and behavioral health. And I believe there's a question as well we haven't addressed yet about FY27. It's in the written testimony, but we don't have anything budgeted for the Deloitte contract. In FY 2027, we're working with DBM to identify resources. DBM's supportive of continuing the contract, which we very much plan on doing. So it hasn't happened yet, but we're working on bringing that item into the budget. All right. So the next set of questions, I'm going to turn over to my colleague, Elizabeth Crum, who's our Assistant Secretary. Thank you, Elizabeth.
Thank you very much. So you have our written testimony related to the Rural Health Transformation Program. And in listening to what our DLS colleagues said earlier, I just want to highlight a couple of things. So we've submitted our revised budget to the Centers for Medicare and Medicaid Services, actually just earlier this week. They have 30 days to review and then let us know what's happening. But we feel confident that our revised budget will be accepted. What happened was we were asked to actually set a budget and apply for $200 million, knowing that we'd be adjusted downwards. So this is just the revised budget to our award amount of $168 million. So we expect that in March, our immediate impact programs, everything from the seeding of primary care practices to getting going with the cold storage on the food side to ramping up Department of Labor existing apprenticeship and then starting to create new ones, apprenticeship programs, those will all begin different parts as of March, once we have funds restricted. And then when we get to our transformation funds, these really competitive grant processes, we are right now writing the RFAs and RFPs and putting the outlines together with our partners. We've stood up regular touch points with all of our partners across state agencies. So this includes the Department of Labor, the Department of Agriculture, Maryland Department of Emergency Management, the Rural Maryland Council, the Health Services Cost Review Commission, the Department of Housing and Community Development, our friends in the State Health Information Exchange, CRISP, and a few others, in addition to our local health departments. We're meeting now to get everything in place, so once we do have those funds unrestricted, they can start their processes, because we're doing a lot of sub-awarding to other agencies, so then they can do their RFAs and RFPs. So that's going to be late spring. I would say probably the first group is ready to go come April, and then there will be several more coming out after that.
Okay, another part of this, I may not have had the mic on, thank you. Another part of this question was about bringing this item into the budget, this grant. It was timing of the award didn't allow for ready inclusion in the governor's budget. So we have talked to DBM. They're open to all the options, right? So, and we have our second quarter projection underway right now to confirm if our existing federal fund appropriation can support this year's grant activities. If not, we might explore a supplemental budget option with DBM, or we might do a close-out federal fund amendment for FY27. Again, the options are a budget amendment next year or doing a supplemental budget item this year. DBM's open. If there's any preference or any thoughts, we're open to hearing them. All right. And the last set of questions were about the cigarette restitution fund. And so the first one was DLS recommends adding budget bill language to make $8.4 million of the CRF special fund appropriation under Medicaid contingent on enactment of the BRFA provision, expanding use of funding from separate account. MDH concurs with this recommendation. Next, MDH should discuss how we'll allocate the reduction of CRF spending from the separate account if Maryland does not receive the $35 million in additional payment assumed in the allowance, and two, the projected impact of this reduction on CRF-supported programs. So following conferring with DBM, the $35 million is included in the overall revenue estimate for CRF in FY27 and is not tied to any specific expenditure. Should the additional $35 million payment not be received as estimated, DBM, the governor's office, and various agencies that receive the CRF will work on a resolution through the FY28 or FY29 budget cycles, depending on the timing involved. And then finally, to align with CRF spending from the separate account across several statutorily required CRF uses, MDH and DBM should propose an amendment to the BRFA to waive in fiscal year 27 only the requirement that 50% of the CRF appropriation support specified programs. So our written testimony, we were still working out the response. So we have an updated response that we'll share verbally here for the record. So we respectfully disagree with this recommendation. So DBM, in consultation with its Attorney General, has advised that BRFA language is not required for this provision, and so believes no BRFA amendment is needed. And that concludes our testimony. Stand ready to answer questions.
Okay, thank you. I kept trying to jump in each time you paused just briefly because we're just all on the edge of our seat here. Thank you so much for your thorough answers. Thank you, Madam Secretary. Thank you, Madam Deputy Secretary. Going back to Delegate Stanko, did you have any final questions in that initial line that you had?
Yeah, thanks, Madam Chair. Just one follow-up, and you touched on this, and actually it's the OLA audit. It was just like a secondary follow-up. So you talked about revenue recognition and timing, and it's kind of a rolling cycle. I guess I'm just looking for clarification. So I don't want to say disagree with the audit, but is your view that the state is not forfeiting the right to collections based on missed timelines?
Correct. This is a issue of revenue matching to expenditures, revenue to expenditures. So there's been no forfeited revenue.
Okay. So, and just want to clarify. So your view is there's been no forfeited revenue, and it may have just been a timeline on when it will be recognized.
Correct. And the majority of it has been collected.
Okay. Mm-hmm. Thank you.
Mm-hmm.
Thank you.
And I just want to say we value our partnership with OLA. their findings, recommendations led to a lot of improvements on our end, so we're not trying to slight them or their analysis with their findings. You know, what they said was accurate. We had a revenue that needed to be matched to its proper expenditure location, so.
Thank you. Thank you for the follow-up. Madam Vice Chair.
Thank you so much, Chairwoman. Thank you so much. Welcome. Looking forward to continuing to work with you all. Let me go quickly just for the record. I have two questions to our tech guy, and I want to make sure that we just get this on the record. I think some of what you covered may apply, but so on page 9 of the DLS analysis, I see that there is a proposed $53.5 million cut to behavioral health, Medicaid provider reimbursements, and almost $149 million cut to the DDA provider reimbursements. Do you want to share more about that in any way, and how we? Can you share any more about that?
I'm sorry, can you point to
Sure.
the page again?
Page 9.
Page 9, okay.
Yep. Of the DLS analysis, there's a proposed $53.5 million cut to behavioral health, Medicaid provider reimbursements, and almost $149 million cut to DDA provider reimbursements. It's halfway down the page under provider reimbursements on 9. Is there anything else that you want to share on that, or? And we can also, you can circle back.
Yeah, let me circle back. I think some of this is comparing to the prior year, so it might take some digging to look into the differences. I don't want to see anything out of turn right now.
Okay, well, thank you very much, and absolutely, let's circle back on that one. The closeout concerns of FY25. Let's go to page 14 of the DLS analysis. The analyst notes that MDH is required to provide monthly and year-to-date data on cost, and this is, we'll just go back to it, sorry. I was gonna, monthly and year-to-date data on cost and utilization rates for individual service and eligibility group, but that MDH has not been able to do so due to complications transferring data between the prior ASO and the new one, which went live last January. You touched a little bit on this, but I'd like this for the record, please. Can you please share an update and anything else that seems critical, because we need to get this data in order to better forecast and make budget adjustments and potentially avoid large deficiencies in appropriations.
Okay, so the data mapping and the marrying of data between, the two ASOs, there's been a process there. We've had to, I think, possibly resubmit claims as well to get it into the new data system, which has also been an undertaking. There's more. Let me pause for 1 second. Okay. So yes, and so it sounds like you're asking about the timing, is that right? Okay, so I believe the process is largely concluded. We're still, I think, with some time within the next, I think we're estimating by mid-February is when we're targeting, kind of validating the data, and so doing final data validations. So that's my understanding of the timing of having this data released. Perry, did you want to?
Hi, one moment. Madam Deputy Secretary of Medicaid, if you'd like to join us down at the panel. Sorry. Otherwise, our friends who are watching, our millions of fans here, are not going to be able to see you and hear your response. Thank you. Welcome.
Thank you so much. Good afternoon. My name is Perry Briskin. I'm the Deputy Secretary for Healthcare Finance and Medicaid Director. Good to see many of you again. Delegate, in answer to that question, yes, there has been a transition where we expect to have that data in February, that those reports will start functioning as they should. So we hope to have that data fairly imminently.
Thank you so much. Thank
Sure.
you, Chairwoman.
Great. Thank you. Thank you for joining us. All right, I see Delegate McCaskill.
Thank you, Madam Chair. I apologize, I didn't know I was next. I kind of zoned into a daycare moment, and I was thinking about the head bone connected to the shoulder bone. and how all this is working together. So I'm trying to piece this together, so just work with me for a second. I apologize. Okay, so I'm going to ask my procedural questions to our tech fellow. I have about 3 questions. Mine's is around home and community-based service wait lists. And so I have maybe 2 procedural questions so I can figure out how all of this is connected in my brain. How does someone confirm that they're on a wait list, and how can they tell their status?
They want to get more specifics.
Come back. Well, welcome. Shall I repeat? I probably caught you off guard.
Good afternoon, everyone. Marlena Hutchinson, I'm the Deputy Secretary for the Developmental Disabilities Administration. For our home and community-based services wait list, it depends on the actual wait list. So for the Developmental Disabilities Administration's wait list, individuals would contact my regional office in regard to their waitlist status. For other home and community-based waiver services programs, it would depend on the office that's actually operating that waitlist. So for like the autism waiver, it would be the Maryland State Department of Education. For the community options waiver, it would be the Office of Long-Term Services and Supports.
Okay, perfect. So it's not an individual confirming, it is the office itself confirming?
The individual would call that office for a status update.
Okay, and then, perfect, so I don't know if this, you're staying with us for a second. So my next question is, are you utilizing public data to reduce your wait list? For example, if someone passes away while on the wait list, do they get removed?
Yes, so with all of the home and community-based waivers, we actually do what we call waitlist scrubs.
Okay.
So we use the vital statistics data to determine whether or not a person has expired. We also look at Medicaid paid claims data and enrollment data to determine if individuals are receiving services from other Medicaid waiver programs as they're awaiting an opportunity to apply for the waiver, because Medicaid has optional state plan programs that individuals may be able to access as they're awaiting an opportunity to apply for a waiver program. We also look for any institutional services that may have come into play when an individual is awaiting an opportunity to apply. For example, if a person is on a wait list and unfortunately goes into institutional care, like a nursing facility, we would check Medicaid claims data to determine that as well. So we're constantly scrubbing our wait list to determine where an individual is at any given time.
So when you scrub your wait list, is it like weekly, monthly, or is it when the opportunity prevails?
Again, it depends on the waiver program, so I don't want to misspeak.
Okay.
For the DDA, we're constantly looking at our waitlist status.
Perfect.
I would say approximately on a monthly cadence for a DDA.
Perfect. So I know you all are actively, doing what you can to reduce and meet your goal for the wait list. So I am looking forward to that 2028 to happen and to see what happens. My last question, Mr. Tech Fellow, and to the panel. The community option waiver was authorized to provide services to 6,348 participants, and 33% of those slots were unfilled. Why are there any unfilled slots?
I'm going to defer to my colleague here, Deputy Secretary Briskin.
Perfect.
Good afternoon. I'm going to have to, I believe, take that back to understand what the delays are. This is with our Office of Long-Term Services and Supports. So I want to make sure I have the right answer for you, so let's take that back.
No, respectfully, thank you, I appreciate that. See, that was I'm trying to put it together, my head bone connected to the shoulder bone. Thank you, Madam Chair.
Thank you, Delegate. Appreciate it. Delegate Ruff.
Thank you, Madam Chair, and just to, well, thank you to the panel, thank you, Madam Secretary, and all your staff. And I wanted to piggyback on my colleague from Baltimore County about the community option waiver question. I'm very, as you know, very interested to know the answer to that. As we've discussed, I have a woman who's bedridden in my district who calls me once a week trying to figure out why over a year and a half she has not been able to get an answer on a reconsideration about her community option waiver being denied. I got an update from you all basically saying she didn't provide all the information needed and that she can appeal it. But I certainly would like to know how that outcome, is what we're looking to do if there is, a great amount of folks not filling the actual slots. So I certainly would like to know the answer to that question as well.
May I respond, Delegate Ruff? Or
Sure.
I do want to clarify one point, which is important because there are different issues. So when someone is having an issue with their application or renewal, they're already off the wait list. They're no longer waiting. So that slot is reserved while someone is going through the redetermination process. So we need to both look at why we have so many open slots and why people are sitting on the wait list, and once they are off the wait list, making sure they can get through the process in a reasonable timeline and fashion, which Delegate Ruff, for the member you're talking about, is not what that is. So we're working on both sides of the problem, but just to make sure that's not the wait list issue is separate from that particular issue.
Okay, thank you. So I want to go to page 10 of the DLS analysis, where it indicates the $55 million cut to behavioral health prevention, treatment, and recovery grants and contracts. Can you guys give us a specific description of these cuts so that we can have an understanding of this line item?
So I can say generally that, the budget amount in FY27 reflects, projected need for services that are especially services that are reimbursed through the ASO. So it's not, I don't think, a specific cut to any particular service, but rather just reflective of projected expenditures. As you've seen in prior years, there's been significant surplus out of Behavioral Health Administration, and so I think this is just acknowledging some of that in the FY27 budget.
And I think, we can get into more specifics also when we do our specific, behavioral health brief to talk about each individual program. But I think to emphasize what Nick said, it is about kind of right-sizing, seeing where the services have been needed and being able to apportion accordingly.
Okay. It just seems to me that utilization of behavioral health services like these would be on the rise, and that I think for us, it was a bit surprising to see this cut. So it would be good to have a follow-up on that as well, to have a better understanding of what you were talking about, the forecasting of expenditures. My last question is about the assisted outpatient treatment programs that were mandated in 2024 to local jurisdictions for them to be established, and that the department would establish them on behalf of local jurisdictions if they didn't. It's my understanding that none of the local jurisdictions did. And then that you guys are going to go into cost shifting of about 25% in fiscal 28. Can you guys talk about the implementation of the assisted outpatient treatment programs and the communication that you guys are having with the local jurisdictions around this year's plan and future year plans?
You want me to start? Yeah, and unfortunately, our Deputy Secretary for Behavioral Health is not able to be here today. But overall, there has been significant communication with the local behavioral health authorities. And as you mentioned, there was hesitancy for the local behavioral health authorities to stand up this program. And so we are working at the state level to be able to stand it up. However, it would continue to be in concert and working closely with our local behavioral health authorities in terms of, what works for different communities.
Okay, thank you.
Okay, thanks.
Sorry, go ahead, sir. I
all right,
couldn't,
thank
tell if, I really can't
was-
see the microphone, I'm sorry.
It's all right.
Thank you, Delegate. Thank you, Madam Secretary and team. Delegate Heinbach.
Thank you, Madam Chair. I represent a very rural part of the state, in Garrett and Allegheny County, so I'm very interested in the Rural Health Transformation Program, and I've tried to read as much about that as I could, and I gather that came about because some concern over the one big beautiful bill and what the impact would be on rural hospitals, and that there was already a trend where rural hospitals are closing or being converted to urgent care clinics. So I just wonder, there's nothing in the budget about the $168 million you got, probably because you got the money right at the end of the year, I guess. But I'm curious, when I read about it, it said that CMS said that half the money will be distributed equally, and the other half will be distributed at CMS's discretion. So the $168 million, was that part being distributed equally, or was that part at the discretion of CMS?
That's the combination.
Oh, it's a combination of both?
Yep, it's the combined amount. I do think at the end of the day, the state submitted a very strong application, in part thanks to your constituents, right? We really engaged with our rural communities to get their ideas of what is needed. And, in the money that we were able to secure, per person who lives in rural areas, we got double the national average.
Oh, that's great. So when you mentioned earlier, Madam Secretary, that the funds would be awarded through a competitive process, were you referring to the $168 million or follow-on, the 168?
That's right. So with the $168 million, it's divided into 3 buckets: workforce, food as health, and innovation to improve access to care. Within each of those buckets, there are short-term shovel-ready projects that we want to be able to invest in, because CMS is also looking for immediate impact of this money. So within each of these buckets, it's split into, more immediate shovel-ready projects, and then the longer-term transformation funds, which is through the competitive processes. So while we are working to, as Assistant Secretary Crom mentioned, get funding out the door, as early as March and April, at the same time, the team is already drafting the RFAs to be able to do those competitive processes for the transformation funds.
Thank you. Just a couple more things, if I could. So I know the federal fiscal year is different than ours, but is there any expiration on those federal funds? Do you have to use them by a certain date, or you lose them?
Yes, so it is done on a year-by-year basis as a collective agreement. So it's $168 million for the first year. CMS will evaluate each year, both, was that $168 million used towards impact? And they said that if not, they could claw back some of that money. And then there will be a determination of what will be provided in each subsequent year as well.
Okay, thank you. When will we know how much money is going to where? Is there a list somewhere, or will there be a list somewhere like Garrett Regional Medical Center? When will I know? And I worry a little bit about it being diluted so much, because I thought it was just hospitals, but it's not just hospitals. It's clinics and federally qualified health centers and other things. So will there be a point in time where there's a list of where the $168 million is going?
Yes, we do have our website where we are posting, regular updates and information, so there will be avenues there. We also have an advisory committee comprised of all of our stakeholders to help both with giving us input into how to best utilize these funds, but then also to be a source of information and outreach for our communities. And we certainly can also follow up directly with you as well on any information that you would like.
The thing I was a little surprised about when I read that, based on the, I guess on the criteria under the bill, there are 18 counties in Maryland that qualify as rural counties, but it also mentions in there that, I think I read that money could go to counties that were contiguous to the rural counties that have maybe a large agricultural. Did I read that right, or does the money just go to those 18 counties that are designated as federal?
We followed and Assistant Secretary Crum can correct me if I'm wrong, but we followed the state definition for what is a rural area for that. And in terms of where the money can go, CMS did provide kind of do's and don'ts, right? What money could be used for and what money could not be used for, and so we followed that as well, which is why funding goes to not just hospitals, because they were very specific that they did not want this money. This money could not be used to just supplement hospital revenue. It had to be used for these transformational purposes.
And I'm sorry I'm asking so many questions, but I'm just very interested in this. Part of that money goes for workforce training, and I read, I think it mentioned University of Maryland, and I think it mentioned opening something on the Southern Shore. Is some of that, Allegheny College of Maryland has a very good nursing program and some other med stuff. Will some of that money potentially go to them for workforce? It seems like it would make more sense to train people where they live so that they don't get you have a better chance of retaining them, I think, if we train people near their home. And I'm just wondering, is that part of the plan?
Yeah, do you want to take that?
Sure. It's definitely a part of the plan, and we agree with you completely. Training folks where they live and giving them the opportunity to grow their career where they live is what we want to do. So there is the opportunity. So there was a mention about there are these area health education centers that exist. There's an AHEC on the Eastern Shore. There's one in the West, but there's never been one in Southern Maryland, despite a need. And these are vital organizations that help connect on growing career pathways, so sort of entry-level healthcare all the way on up. Coordination with community colleges and other training programs. So what we've proposed to do is spend dollars to actually stand up an area health education center in Southern Maryland. So Southern Maryland has one, and then expand the programmatic offerings on both the Eastern Shore and in the West. And then things like Maryland Rural Scholars Program, which is a part of the University of Maryland system. We know that Meritus out in the West has grown in terms of their clinical offerings and training programs. Dollars then to be able to grow and expand their programs, in addition to those entry-level apprenticeships, or somebody wants to ultimately go into the healthcare field, but maybe they're starting as an environmental services person inside of a hospital, and then they want to become a patient care technician, and then they want to go get their nursing degree. Through staying within the community and in that hospital, working through the community college and secondary education, those are the additional programs we want to be able to build through these dollars.
Okay. Oh, thank you. Thanks for your patience with the questions, and thanks for what you do. I mean, obviously you have a very critical mission. It's important to all of us, and a lot of people depend on you. So thank you. Thank you, Madam Chair.
Thank you, Delegate. Thank you, Madam Secretary and Deputy Secretary and team. I have, I think, the two final sets of questions here. So I'm going to start with the Nursing Home Quality Assessment Fund, which I just texted the Deputy Secretary. I was like, don't go too far. I might need you in a minute. So I'm wondering if, welcome back. I'm wondering if you can please talk with us about the Nursing Home Quality Assessment Fund, how it works, what's its purpose, how much is collected. I found the FY25 report, which I understand is mandated annually, so we found that. But can you talk a little bit about sort of generally how much is collected? Is there a Medicaid match on that fund? And how much of those dollars, like what percentage of the fund is turned back and given back for incentives to improve quality? We'll start with those.
Thank you so much, Delegate Shetty. So yes, we have in Maryland three provider assessments, also called provider taxes. And one of them is on nursing facilities. It's a 6% on top of nursing facility revenue. And so we collect the whole concept of a provider tax just generally in Medicaid is that you tax all of the providers, whether they're Medicaid, commercial, Medicare, you take all that money and then you distribute it just to the Medicaid program. And the advantage that a state has to do one of these provider taxes is, yes, you can pull down a federal match. I believe in this case, it's a 50-50 federal match. So if we take $40 million, we can match it with another $40 million, so suddenly there's $80 million, and then we can distribute that out among Medicaid providers. And so the nursing facility tax operates the same way. I was just messaging with my team because I want to get the latest numbers, but it's around, I believe, $150 million a year for the nursing facility tax. So we collect that. That $150 million is total. So we collect part of that. We double that with federal funds, total $150 million. 100% of that goes back to our nursing facilities in a variety of ways. Number one, it's through rate increases. So this year, Medicaid was flat funded, so there was not a nursing facility increase. But from FY 19 to 25, each of those years, there was a rate increase between 3 and 8%. And so part of that was funded by this nursing facility assessment. Another area where it goes is quality. We have a pay for performance and pay for improvement program with our nursing facilities where we reward higher performing facilities, and how we do that quality payments is also funded through this nursing facility assessment. Whatever is left over, that just goes to sort of baseline reimbursement for our nursing facilities. The statute that put this nursing facility assessment in place required, I believe, that 65% of the payments of what came from the nursing facility assessment had to go to new payments. It couldn't just go to normal reimbursement. It had to go to the rate increases or the quality payments. So we are a big fan of our nursing facility tax. I will say CMS, the Centers for Medicare and Medicaid Services, as part of OBA, has made changes, and we've talked about this, to the provider taxes. Thankfully, our nursing facility tax, the impact will be relatively minimal. Nursing facilities were exempt from the 3% threshold, 3% of revenue, so our nursing facility tax is 3.5%, 6%. One concern with the nursing facility tax is we know it's not broad-based, meaning there are some nursing facilities that are exempt from paying the tax. We could see that CMS comes back and says, Maryland, you must tax all providers equally. However, guidance and new regulations on provider taxes have not yet been issued, and we are waiting for additional guidance from CMS on that matter.
Thank you. That's super helpful and in the weeds. I love that. Can you and your team please provide a breakdown to DLS and to our offices as well of just all that you just talked about? Like, this amount was collected in FY25. This is how it was expended?
Absolutely.
That would be extremely helpful. Thank you. And then the next set of questions I have, also don't go far, please, is related to our budgeting processes and the caseload estimate numbers. So I can only imagine it would be absolutely impossible to budget for these massive programs without having somewhat of an accurate guesstimate of the likely caseload that we'll have in Medicaid and CHIP, all of the various programs. So I wanted to get in some questions on Appendix 2 of the DLS analysis. That's their breakdown of the caseload estimates. I wanted to know what the Medicaid enrollee case number is based on, please.
So we know that the majority of losses due to OBA will not happen until the start of fiscal year 28. And so I believe we kept our our enrollment relatively steady compared to what it's been. But I can get more detailed information for you on our calculations there.
Yeah, I think it would be really helpful to understand, just to make sure that, we are doing our best, at least, it's so hard, right? This is a number I'm certain has so many factors beyond predictability, right? But I think to understand at least what some of the factors are that you all are using to get to this specific number for your budgeting purposes will be very helpful. And then I see on that same appendix that there is a 924-person drop in CHIP enrollment predicted for FY27 and 15,394 individuals drop in the ACA Medicaid expansion population. What's that based on?
So I have one comment there tying back to the last question. So the FY27 budget for Medicaid somatic services, behavioral health Medicaid, they factor in enrollment adjustments to ACA adults starting, I believe, in January of 2027. So I think that ties into both questions. That's part of, I think, the reduction you're seeing, and also was part of how our enrollment assumptions played into FY27 budget development with respect to HR1 implementation.
HR1 implementation, got it. And where do we think that these individuals will likely get coverage if they're not covered in Medicaid or CHIP?
So we are having those discussions, I think, internally. We do not want, if we can help it, to have all of these individuals end up in the emergency room. So do we point them to health centers? Do we provide other limited coverage options for these individuals? I think we are looking at, and I think that also went into these numbers, those non-citizens who are going to be losing coverage October 1st, and trying to do a dive onto where they are, do they have disabilities? So we are looking at that very closely and look forward to working with the General Assembly on options for those individuals.
And if I may, I will just say that first and foremost, our goal is to make sure that everybody who's eligible for Medicaid can stay on Medicaid. And that's why it's been a priority in the governor's budget to be able to fund what we need to do to implement HR1, to be able to modernize our enrollment and eligibility systems, to be able to put what we need in place so that people can navigate through the process when there has to be an every 6-month redetermination. When work requirements start, the added benefit of engaging in a healthcare workforce in rural areas is then you can give people job opportunities, right? And so, wherever we're able to, and we look forward to continue working with all of you as well on that, because where people are eligible to stay enrolled, we want them to be able to stay enrolled.
I would venture to guess that is a priority, a shared priority between the legislature as well. Yeah. So. I don't see further questions from my colleagues. Thank you, Madam Secretary. Thank you, team. I know we have many hearings to come with you, but congratulations, team, on making it through your first one with us. I hope we weren't too harsh on you, but appreciate the opportunity to have the dialogue to really dive into the proposed budget, and look forward to our next conversation. Thank you. Our meeting is adjourned.
Thank you.
Thank you.